So we are live this evening. So I am gonna kick off. I think just make sure we got all the technical stuff right. I'm gonna put away my Facebook feed because it's on a bit of a delay. And what I'm gonna do is just do it off the computer. I'm not sure that means I'm going to be able to see any comments. I'm going to try and see if I can get that with my iPad, but that doesn't seem like that's coming through. Yeah, so I'm not sure I'm going to be able to see any comments right now. I'm going to have to check that periodically. Right, what we're going to do is we are going to have a little chat about exercise and movement and back pain, three of my favourite subjects, and yeah, so I've got a whole bunch of slides that I want to get through. I've gone a bit fancy, use the OBS software again so that we can have some graphs and some data and some bullet points and all that kind of thing, just to make it a little bit more visual and a little bit more interesting. Might be a tiny bit noisy. I'm going to leave my window open. We're having a bit of a heat wave here in London, and unless anyone wants to see me die live on Facebook from like heat exhaustion or some kind of heat stroke or something, we might just have to brave a little bit of noise from outside. That still possibly might happen, so you know, tune in and you never know what might happen, right? But as I said, we're just going to dive in and we are going to talk a bunch about exercise and movement and back pain and kind of see where we get to. So let's see if all the technical stuff can work. So I'm just going to transition there to the first slide, and hopefully you've got little old me in the corner, which is fantastic. I'll give a big shout out to Greg Lehman who told me how to do that, which was really, really simple, but for a kind of a not that smart guy like me, it was a bit of technical wizardry and genius. So that's kind of cool. So we are going to kick off then and just start to think about lower back pain and movement. So firstly, look, exercise and movement is a real positive for lower back pain. This was a paper that came out last year just suggesting that exercise alone or in combination with education is fantastic for lower back pain. But we know that, right? So really it's being able to get this information across to the people who really need to know it. And we're going to look at some other information in a few slides that kind of lets us understand that although us evidence guided or based people know that exercise for back pain is fantastic. Not a magic bullet, I would add, but certainly can be very, very positive in the prevention. You know, it's getting that across to other people. And one of the ways that I think we can be stronger about getting that message across is being able to understand that there is data to support it and that we can provide evidence of that data. And, you know, hopefully some people along the way are a little bit swayed by the powers of science. Because science hopefully can be pretty persuasive. Not for everybody. Some people prefer opinion to science, but that is an entirely another debate. Now, one of the problems I do think that we have with the idea of exercise and movement for lower back pain is we just think that people can just pop off, do a few exercises, and suddenly their chronic back pain that they've had for the last 20 years is going to disappear. Now, that would be a really great thing if that happened all the time. I'm sure it has happened. There's a really great saying from Louis Gifford that kind of suggests that, you know, that there aren't many magic bullets. I think he said about pain education that no one ever just got up and kind of tapped their heels together and ran away and suddenly, you know, they were perfectly cured about hearing about a few ion channels and that pain is in the brain, etc. Right? So exercise is another example of that. The exercise for lower back pain, although shows promise and is really positive, it doesn't kind of tell the whole picture, and nor should it. So we understand that human beings are complex. We understand that they're multifactorial, and that just simply doing just, you know, finding just some exercise to do probably won't deal with all those factors. But it is at the same point a really, really promising thing as well. And this was a paper that was last year in JAMA, and is a really good piece of information. Now, one of the other things that we know is that lower back pain is, we don't really know where it comes from. This is a great paper again for this year, just about kind of understanding a little bit more about what happens with lower back pain. There seems to be a bunch of people that thinks that back pain is always to do with the disc and is discogenic, and most of the data suggests that that isn't true. Radicular symptoms account for, probably under 20%. And this paper and a previous paper by Peter O'Sullivan would suggest it's between 5 and 10%. So 1% is kind of serious pathology. 80% of that 1% is spinal fracture. So we get a lot of other things that we can kind of dig in there that aren't that serious, So most lower back pain is non-specific. Now, some people may suggest no back pain is non-specific. I've heard that suggested before, that there is always a specific cause. Maybe we can't always tie it to something specific in terms of a structure or a specific pathology. And again, what we do know about back pain is it tends to be really quite multifactorial, which is, it's important to understand. It's really, really important to understand that that we actually don't know that much about lower back pain. And this is a really, really great quote. This was something that I saw a guy on Twitter post recently, and then I did Google it. It was from a conference presentation, so it isn't actually from a paper, and there may have been some artistic license taken with it. I don't know, but certainly this guy is in Nachmanson saying, I've been studying back pain for the past 50 years, and if anyone says they know where back pain comes from, they're full of shit. And I think that is a really, really good saying for lower back pain. I think it's a really good saying for most pain in general, to be honest with you, that we haven't got the foggiest where it comes from. Certainly with back pain, it's one of these things that we really don't know where it comes from. And yeah, I just think it's really important because, I often see that people are, quite certain about, they know exactly what's causing it, my anterior pelvic tilt or my short leg or my this or my that or the other. And actually there's a lot of really, really clever guys who've been studying these things for a long, long time, who know far more than I will ever know. They've probably forgotten more than I will ever know. And if these guys can't get it and work it out, then I'm not doing too good at that, So really good quote. I've been studying back pain for the past 50 years, and if anyone says they know where back pain comes from, they're full of shit. I'm going to second that because I haven't got a clue. But that doesn't mean that we have to know where it comes from to be able to help people. It may be important that we do know that certain things have been ruled out, as we said before. We know that 1% of back pain has a serious cause. Another 5 to 10% may be kind of serious in terms of, kind of ridiculous symptoms, and that can be from a whole bunch of different aspects. I've got to give a big shout out to my mate Andrew Cuff. I had the pleasure of going along to his spinal pathology red flag one-day course over the weekend, which is absolutely fantastic and really reminds me, you've got to keep sharp on the important stuff. So it's really important that if you are first point of contact, or you should remain vigilant throughout helping someone through back pain, because there's some stuff that can kind of masquerade and give out the impression that it's musculoskeletal. And if we take that, the chances are these things aren't very serious, the 90%, but at the same point, you want to find it if it isn't. So one of the things that's really, really important to understand is it's really complicated, and single factor thinking is a really big deal when it comes to back pain, that we think it's to do with a muscle firing, or we think it's to do with someone having a leg length equality, or a posterior or an anterior pelvic tilt, and all these things. And exercise and movement might fall into that bracket, that we see it as a single factor. And actually we should really understand that it's massively, massively multifactorial. So this is from a paper from Peter O'Sullivan in 2005 in Manual Therapy. And really, I'm not going to go over the slide. I always say to people, what does this slide say to you? And everyone says, it looks like it's complicated. And I would say, absolutely, it's really, really complicated. So if you think you've got this answer, that it's a little muscle firing, or it's this or that or the other, you're probably wrong. A lot of the time, these things are, sometimes we can have situations where things are simple, and we sometimes have situations where things are complex. but they probably lie on a continuum. And it's probably not just one singular answer across a whole bundle of people. So this great paper from Peter O'Sullivan, I know he's probably changed his mind on a few bits that are in this paper. That slide just tells us that, it's complicated, all right? So there's a whole bundle of different things that might impact people's lower back pain. We have things like stress. We have things like sleep. All these things have been really well tied into back pain and pain in general. Again, they could all play different proportions of a role. It could be, a lot of, for one person, it might be a whole bunch of kind of different reasons. For another person, it might be one reason in a little bit more volume, if you like. We have things like belief structure that may not always affect people physically, but what we do in terms of our beliefs affects our physical action. So if someone believes, for example, exercise is going to damage their back, or it's not the right treatment, then exercise and movement aren't going to be something that person is going to do unless you kind of are able to give them the information and the benefits of what it might be able to do. Previous experience, again, a previous experience influences our current belief structure. We might have things like our emotions. We might have things like social and work factors. And one of the real big things that we're seeing at the moment that's coming out, and this has been shown with a number of different injuries, from whiplash to lower back pain to shoulder issues, is a predicted expectation of recovery. Again, this may directly influence what people do physically. And that's really important, that if people don't think that what you're doing for them is going to have a positive effect, then that's going to directly influence how much of that thing that they do. So someone's expectation of is it going to work? Is this something that fits in with their vision of recovery? So predicted expectation, really, really big deal. So you want to find that out, and if it's contrary to the approach that you would like to take, it's probably something that you need to be able to discuss with someone and find out if that's something that you can affect and alter through your explanation of what you're trying to get across. So one of the other things that's really important in back pain is that we understand that it kind of it has a trajectory. So this is a really great paper from Kongstead in 2016, and what they looked at was the kind of current concept that things are seen as acute, subacute, acute or chronic, looking at the kind of current duration of the episode that someone's in. And I think a lot of the time that influences how and what we do to people. So if we look at the long-term trajectory of something, we might see it have a more chronic nature. If we look at a very short-term view, we might see it as much more as an acute scenario. And it might affect our approach. And if it affects our approach, then that might affect the overall trajectory and creates this scenario where we see that kind of boom and bust cycle in terms of doing something, pain relief, and coming back down to baseline and then going back up and coming back down, etc., etc. And I think we need to see exercise and movement as more of a long-term strategy that's designed to potentially reduce some of those peaks and troughs. And again, I like to think of movement and exercise as a journey rather than the destination. So I kind of, helping people understand that movement and exercise is really not a cure, it's almost a management, if that makes sense. So we know that movement and exercise are part of healthy human beings, and that to be healthy and to remain healthy, that this is something that we want to kind of keep on doing and keep on top of. And there's also some kind of graphs that they used within that paper, borrowed it from another paper by Macedo in 2014, and just shows a number of people over a 12-month period what happened with their symptoms, showing that different people have different experiences and that we may interact with them at different points and may take different approaches. If we look at it over the longer term, we may see or may take a much more consistent approach that may not be based around just affecting people's symptoms in the short term, but maybe a long-term approach to recovery. So I think that's a really, really important thing to do. I think often we're trying to decrease symptom, get some of that pain down, and that maybe makes us choose ways of treating people that have short-term effects. Not to say that they're wrong. I'm not getting into that debate, but certainly thinking about what do we add into that as well? How do we also make it a long-term approach that maybe has an effect a little bit more than over the short-term symptom response? So this is a paper by Kongstead, absolutely fantastic paper. I think it really highlights some of the major issues that we have in back pain, and the fact that an education and movement and exercise-based approach is probably more of a long-term one than a short-term one. But we understand, if we look at here, you know, if we take the guy on the triangles, or the girl, I don't know, that we see that there's quite a few different stages to what they're experiencing, you know, and that how we interact with them at different times may influence the overall trajectory of what we're trying to look at. So they're just some kind of background aspects behind back pain that I think are really important to know. But let's think a little bit more about beliefs around exercise and movement. And these are the big things that interest me. So what the therapists, trainers, and patients, clients think about beliefs around exercise and movement, because that really influences kind of what we're going to be able to do with people. You know, we talk a lot about kind of patient or client belief. A lot of the time, I think therapist, trainer belief also has a really big effect on what gets done as well. So I think that's really important to understand. So this is a great paper by Ben Darlow. And this is these highlight the big challenge that we face often with getting people to do a movement and exercise based approach to helping with their back pain, is that people have kind of entrenched beliefs about what is the right thing to do in these scenarios. So this is Ben Darlow's over in New Zealand, really does some fantastic qualitative research, which I think when we were understanding beliefs and expectations, etc., qualitative research, really fantastic, often kind of maligned in favour of more, you know, quantitative or hard science, you might call it. But these are really important things. So if we look here, beliefs about back pain, we see that 69% of people believe that they should take it easy, that they should just just rest their way out of pain. And we actually know that we may want to do that if things are really, really serious. But, you know, the latest kind of guidelines from NICE and people like that really suggest that, you know, things like rest aren't great for back pain, and they aren't great for a lot of musculoskeletal complaints, you know, that we need to keep people active and moving, not just from a physical or a physiological perspective, but also from a psychological perspective, you know. So 69% of people believe they should take it easy, which is a huge proportion of people, you know, which is a real barrier to an active approach, right? 59% of people believe that if an activity causes pain, it should be avoided in the future. So if I get pain bending over, that I should then avoid bending over. Now, I think there's a good example, or I think it's fair to say that if something causes us pain in the short term, that maybe that's something that we should take out, you know, that if it's an aggravating activity, and I go back to kind of the sin analysis and the Maitland system, etc., which I was taught, and, you know, taking away some of these aggravating factors can be positive, right? But we need to add these things back in as well. So 55% of people believe exercise risk outweighs the benefit. Again, more than half of people believe that exercise, the risk of it outweighs the benefit, but we know that it can have a really, really positive effect. So even before we do the physical thing, you know, we argue about what's the best exercise, what should you do, what shouldn't you do, what muscles should you get firing, etc. One of the things that we have to overcome for a majority of people is, first, they have to understand that exercise isn't a risk. You know, it doesn't. It only in certain cases might it actually be a risk, and those cases are pretty low if we look at the percentage. 35% of people, a third of people, believe bed rest is the mainstay of therapy. When actually, you know, the information that we're now starting to understand is that activity is the positive thing. So these beliefs are a huge problem for back pain. So you may say to someone, I know, I've got the answer, you know, this is what we're told, etc. But we also need to work out what people believe, what they think is the right approach. Why do they think this? What are the barriers that they have towards performing? So we know there's been a couple of papers into adherence with exercise in general. Number one, in a paper from a couple of years ago, from 2010, was that exercise makes pain worse. So if you believe exercise is going to make your back pain worse, then you are not going to do it. So the benefits, the physical and physiological benefits, just will not occur. So really important that we start to understand, what do people think about what you're trying to do? You know, do they understand why you're trying to do it, what the benefits are? You know, and beliefs fascinate me. They're much more important than the physical bit, because if I don't believe in it, I won't do it. The physical bit becomes massively redundant. So that's really, really important. Great piece of qualitative research. So we have a few beliefs that have built up around kind of people or people in general. And this was a paper from 2007. And what they wanted to find out here is, you know, do things like low muscle strength, low muscle endurance, mobility, etc. These was prospective studies, so it's not retrospective, it's not longitudinal. You know, what they're trying to find out is, you know, does this have, you know, we can measure people when they develop back pain, we can see some of the factors that are related. Very important, prospective research is in general. And, you know, one of these beliefs that we have is we should load up people, you know, we need to get strong, etc. with back pain. And there just doesn't seem to be this link between strength and back pain. So the belief that people are weak and they need to, you know, get stronger doesn't seem to be something that's particularly associated with back pain. Again, which is really, really interesting and it's fascinating. And this is why we need to be evidence-based and understand what we're trying to do. Now, building confidence may be another factor. But we're going to talk a little bit more about that in a minute, and some of the psychological aspects that we see or potentially don't see. But we often have a belief structure that we need to get people stronger and people are weak. Doesn't really seem to be the case with lower back pain. One of the other fascinating things is, this is a paper I use a lot with teaching, is about kind of the exercise that we use. If we use a strength exercise, do we have to see an improvement in strength to see a corresponding improvement in symptom? And people like Anne Mannion did this lots and lots with things like core firing. So if core firing changed, did it have an effect on the outcome, the clinical outcome? So muscle firing, if it improved, whatever that means, did it have an effect on people's symptoms? And we find that it doesn't. So in this paper here from 2012, what they looked at is exercise for strength, flexibility, stability, mobility, a number of different factors. And they actually found that changes within the targeted aspect of performance, so let's say strength, you didn't need to get stronger to have a positive clinical outcome. So again, that throws into kind of a bit of disarray again, what we think about, we know about exercise. So generally with exercise, what we're trying to do is, you know, affect a physical measure. So exercise has this physical effect that, you know, we need to get longer, stronger, blah, 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 blah. And that doesn't seem to be the case. We actually don't know why exercise works for pain. So we can go back and think about how exercise works for, you know, becoming more physically active or physically able or able to lift stuff and, you know, targeted aspects of performance. But we don't know a lot about exercise and how it works for pain, and that's really important. And I think there's a debate that's very, very similar to manual therapy, that manual therapy now, you know, if there are analgesic effects, and I don't want to get drawn on that debate, you know, why do they occur? So they're probably not because we're repositioning. They're probably not, you know, for the more physical biomechanical factors. It may be more descending inhibition, and it may be more belief structures, etc. And potentially that is the same for exercise. And why that might be important is because the things that we focus on in exercise to have these less physical effects or non-specific effects may be different to those that we look at for performance. So we don't know how exercise works for pain. We don't really know how exercise works for back pain. But I think we do know that exercise can be positive, but it isn't a magic bullet. Okay, but one of the big things that we need to overcome first is people's belief and practitioners' belief about what they're targeting and affecting. Again, one of the big things that we've got is there some magic exercise? You know, recently there's been talk of, you know, heavy loading, etc. is a magic exercise for back pain. Again, I don't think that's true or anything to support it. Previously, we were starting to look at, you know, the TVA, and this was a great paper from Ben Smith that packages up all the papers that I've talked about over the past few years, and have been some very popular blog posts, kind of wrap them all up into one in a systematic review with a meta-analysis. And they kind of say, actually, there's no information that actually tells us that things like core stability exercises are any better. But interestingly, we can spin it both ways, because core stability exercises may not be any worse either. All right. So there can be some really positive things that may live in low load exercises such as Pilates and core stability exercises that might be really good for people when they are more sensitive, and when they are don't want to move their bodies around, and you're likely to cause them to flare up, etc. So there can be lots of things that might be novel. It might be graded exposure. It might be a clinically relevant treatment. It might be that you're creating movement and the person feels that it's relevant because it's in the right body part. There might be a whole bundle of different reasons that might be not specific to the core stability exercises themselves, but within the belief structure of the person that you're trying to do it to. So that there isn't this magic exercise, but I think we should look at all exercise and think, what is in that exercise that might create a positive response? So there might be some good things in Pilates core stability that have an effect, but also if someone is very rigid and stiff and stable anyway, which is a behaviour we see from people with lower back pain, I might not want to cause more of that behaviour. It may be actually we already see some conditioning between muscular behaviour and kind of pain and that kind of stuff. So there isn't really this magical exercise that we see. Some of the big stuff, it isn't some physical factors. This is a paper from 2002 or 2003. These guys are from the University of Tehran over there in Iran, and they looked at physical factors. So they looked at size of lumbar lordosis, for example, pelvic tilt, leg length discrepancy, length of muscles, and they found that none of these factors were associated with lower back pain. They did find some association between endurance and weakness, and association obviously is association and not causation. So could some people be weaker through disuse? Potentially. Could they be weaker through pain inhibition? Potentially. Certainly we don't see pain in endurance as something that needs to change or something that is prospectively linked into lower back pain. But these physical factors we see here, such as the lumbar lordosis, the pelvic tilt, the leg length discrepancy, etc., they're just not linked in. And the amount of people that you hear waffling on about these factors curing back pain, etc., stretch your hip flexors. I get spammed with these emails sometimes, oh, your anterior pelvic tilt, oh my God, your leg length. And it's real, it's a load of waffle, really, to be honest with you. Again, bringing it down to this singular physical factor when we know it's just got a shit ton of different factors in it. All right, so really important. So physical factors, again, something that we don't really see really strongly linked. If we see it linked in any way at all. Another one, bending is bad. So this was a paper from a couple of years ago, 3 years ago, and they looked at duration of bending and the kind of degrees of bending in Danish blue-collar workers. I think the Danish are a really bad bunch of people to do any kind of exercise in because they're just too damn happy, and I'm sure that affects the outcome of studies. Their happiness is off the charts. You need to take really miserable people like the British and study them, I think, rather than the happy Europeans. They kind of make me sick, all these happy Europeans. They're just too damn happy. But here in this paper, they took a load of blue-collar workers, and that they found that actually that a higher duration of some of the forward bending positions seemed to be actually protective, which is really cool. And actually the larger bendings weren't negative, if that makes sense. So these smaller bendings seem to be actually additive and positive, over 30 degrees, but over 60 degrees and 90 degrees weren't negative, okay? They just didn't seem to have a protective response. So the idea that bending is bad, I saw Derek Griffin popped a paper out yesterday. Derek always has a knack of bringing out some really good papers, and he showed a paper about vineyard workers, and I think this is from the last couple of days. And again, all these vineyard workers are spending all day bending over, planting things, pruning things, etc. And it didn't show a link between, I think it was reported pain or pain pressure threshold, which is really cool to know that we've got more than one paper. So is bending bad? I don't know, but it would seem the data that we do have suggests potentially bending isn't as bad as we might think it is. And it may not be bad in any way, shape or form. But I'm covering my back. That's really important, right? So here's another paper that again, I think we have a simplistic view of movement and exercise, that just getting people to move more will just suddenly fix back pain. So just do some exercise. What's wrong with you? Get out and do some exercise. Oh, it didn't work. You didn't do enough of it. That might not be true. This paper here looked at physical activity as a U shape. So what they did was that they looked at activity, and I think this was in the Netherlands, in Holland. Again, ridiculously damn happy bunch of people. And what they found actually was that modification of activity is kind of on a U shape. And what they mean by that is that if you get people who are very sedentary to do more, it has a positive effect. Or if you modify activity of people who do a hell of a lot, it has a positive effect. But there's a whole bunch of people in the middle of this U where simply modifying activity may not have this just magical effect. So a lot of these exercise studies that we see that compare two exercises tend to be with sedentary people. So if you take sedentary people and get them to do anything, it tends to be positive. So they are up the top of the left side of the U. If you have people who do loads and loads of activity and they're at the top of the right side of the U, then bringing them back down may also have a positive effect. But there's also a whole bunch of people at the bottom of the U where just modifying activity may not have such a big effect. And that's where we maybe need to look more at habits and behaviours and things that may start to be conditioned or coupled with pain, all right? And again, another concept, again, that ties into this, people are weak, people just need to move, etc., is that in this paper here, they looked at disuse and physical conditioning over the first year of a bunch of patients who were diagnosed with lower back pain. And they actually found that there was only a small number of people that didn't actually modified their activity. So they did less activity. So there was a whole bunch of people, the majority of people, who kind of carried on the same and carried on as normal. And they didn't find that physical conditioning was a big deal. And there's been a few studies that have showed that people with chronic pain aren't just simply physically deconditioned, and they have changes in their activity. So really important that we understand that activities on a U shape, people who have long-term chronic lower back pain aren't just simply weak or don't move or don't use or whatever. So again, it seems to be more complicated, and that's really important to understand, that there's more to it than just getting people to move. And I think that's important, because I don't think we want to sell people on this. Just load it, just move, just do whatever. Because I don't know if that seems to be the case. Okay. So another thing that's kind of really got popular is the idea that if people have fear of movement, what we're going to do is we're just going to do, just load them up, do all these exercises, to prove to them that they're strong, prove to them they can use their body. And while this sounds really positive, again, a generalized approach to something very specific such as fear might not be something that has the desired effect. I don't know whether it will have effect. There's a lot of N=1 going on. But what they found in this paper last year is that actually fear of movement wasn't associated with objective and subjective reports of activity and disability, etc. So people still use their bodies and still move their bodies. They weren't deconditioned. So so what it shows us really is that fear avoidance and fear of movement might be very, very specific. So doing generalized things, people are already doing generalized things where they're using those body parts. They're not deconditioned. They don't show lack of strength or activity or time that they use their bodies. So again, I think this is really good information that tells us that a lot of these things are quite specific and not very, very general. Although I think we're starting to think that we can take very, very general approaches to exercise and movement for quite specific issues such as fear avoidance. And I think if you look at the work of Zussman, if you look at the work of Yonez, if you look at the work of Herta Floor and their discussion of pain memories and things like that, these things are quite specific and based around specific proprioceptive signalling, contamination of these signals, etc., classical conditioning, Pavlovian stuff. And I think it's really important to get into some of that information and understand it a little bit better. But we don't see this generalized thing going on, right? Really, really important to understand that. So general approaches to specific things such as fear avoidance, I think the jury's well out on that at the moment, right? So this is what really interests me. is that do people with lower back pain have different movement habits? And one of the reasons is this U, right? So if they're not inactive, if they're not modifying activity, they're not sedentary, etc., then are there behaviours and habits that people have? And I think chronic pain is often more about behaviours and habits and learned couplings, etc., rather than more physical factors. So do people with lower back pain have different movement habits? And I think there's more than enough data to suggest that for a subsection of people, that might be really important. So just general modification of activity might be important for people who are sedentary. Modification of activity might be really important for people who are very, very physically active, don't get enough rest, you know. Kind of, you look at kind of Tim Gabbett's work with spikes in loading, etc. That might be really important. But then there might be all these people at the bottom of the U that are about beliefs, habits, behaviours, and that's really important. So again, no magic bullet. So this is a paper from Xiang, BMC recently, and again they took some kinematic data. What they found was when you increase movement speed, actually movement range decreased. So people braced, they moved less, and we could say as the threat demand increased, people's protective responses increased as well. So they found that people with lower back pain moved with a specific stereotyped strategy. All right, and again, the idea that this may maintain elements of chronicity. These behaviours maintain elements of chronicity. So again, something that's really consistent in lower back pain kinematic data is we see much lower levels of variability. Now, again, that's something that I'm pretty into. It's my bias. I'll put that up front. You know, so if it's not your bias, that's fine. I think there's more than enough data to open the conversation. And again, what we see here is data from these people. So these movement graphs are about speed. So different speeds show different levels of movement. The blue guys are the controls. The black line are the lower back pain groups. And first thing that we see is the graph on the left-hand side in degrees goes up to 60 consistently for the people with who have not got lower back pain. In the black graphs only go up to 40. So instantly we see decrease in range of movement. Next thing that we see is a decrease in the variability. If we think about all the different people, the participants of the study, they all had varying movement strategies, etc. But we see a decreased variation between different strategies, and that's probably intra and inter between participants as well. So that's kind of really interesting. Again, another paper that came out differently. They looked at difference in lumbar spine movement and the kinematics. Me and a guy on Facebook had a good chat about this, Andrew Vygotsky. We were debating that they weren't measuring stiffness, but probably the predominant mechanism was an active stiffening of the muscles. So subjects with lower back pain displayed less spine movement than controls across all three planes of movement. This was most pronounced in the sagittal plane, in flexion and extension, and this was in a step-down task, so that kind of makes a lot of sense, that if you step down in the sagittal plane, you're going to have more trunk displacement. As we can see, the controls versus the lower back pain group, we see less movement in general. So again, protective responses. And it's important to understand this, that people tend to have increased trunk or decreased trunk movement. We could say that's because of active stiffness or stiffening of the muscles or decreased flexibility, whatever you want to call it. I'm quite happy to suggest that's the hypothesis that I have from why it occurs. And again, if we're thinking about those at the bottom of the U, this might be quite important. We see this in a great paper from Deborah Fowler, and they used a whole bunch of fine wire electrodes, and they stuck them in different points of the erector spinae. And what they found is that the healthy control group, as they went through a lifting task, and we see the lifting task, the kinematic data there, as they went through the lifting task, they redistributed activity to different portions of the muscles. So they had variability, and that's probably really, really important for things like endurance, for creating different coupling patterns between kinematics and kind of neural feed forward and feedback processes, and maybe pain responses that are coupled. In contrast, the lower back pain guys had a whole bunch of movements that just created the same activation of the muscles. They had a habit, they had a stereotype strategy. And it clearly differentiated between the two groups. So again, could it be that we don't see as much movement yet? Because we see that on this graph here, the control group on top, just moved less. They had a greater range of movement during this box lifting task. So again, is that because of active stiffening? I suspect it is. We can't tell you that that's completely the main mechanism, because there might be some passive stuff. It would seem strange why that might be, but there's a lot more clever biomechanical guys than I am. In fact, there's a lot more clever guys in most things than I am. But here, really interesting that we see kind of movement pattern variability if we were to look at kinematics externally, but then also when we look at intramuscular activity, what's actually happening within the muscle itself, we also see a decrease in variation. So it'd be interesting to see the kinematic variability measured as much as the intramuscular variability, see if we can tie some of that up. But really interesting stuff, right? And again, we have that movement data there. We have a paper from Laird, I've gone on one too many, that compared lumbopelvic kinematics in people with and without back pain. 43 studies found on average people with lower back pain have reduced range of movement, difference in proprioception, and moved more slowly. Again, this is probably to do with changes within active stiffness of the trunk. And again, whether these deficits exist prior to lower back pain, I don't know. I'm not interested in I'm not interested in causation. What I am interested in things that maintain chronicity. So it might be that we have an initial event. It might be we have a response to that. And then it might be we have a long-term behaviour that maintains some of these responses that people have and belief structures that they build. Really good paper again from Laird. So again, we have a paper from Hodges, and you can see in the right-hand corner at the bottom, they created some really cool machinery. This time they did actually look at active stiffness, and that's why they built this crazy machine that did all this crazy stuff. Not enough time to go into it now. But they found that in the lower back pain group, trunk stiffness was increased. They had kind of increased reflexive activity. This machine had a whole bunch of pulleys, and it had a whole bunch of dampening and all sorts of things going on. If anyone wants it, I can pop it over. But again, what they're suggesting is, does it have consequences for reoccurrence and maintenance? And I think that's really important when we're talking about a long-term chronicity, that when we're talking about this trajectory nature that we see from back pain, it's really important that we think about some of these behaviours. So for sedentary, it might be that movement in a general sense is really important. For some people that are active, that are conditioned, etc., it might be some of these behaviours that are more important to start to think about. And this is another great paper where they looked at variability again. So they looked at counter rotation between the trunk and between the thorax and the pelvis. My anatomy isn't great, but I know in between the pelvis and the trunk we have the abdominal muscles. I think that that's something to do with low back pain potentially, or what goes on around the abdominals and the lower back. Not sure you need a PhD in anatomy to know that. But what they did here is they looked at the variability between the two rotations. What they actually found is that between the two groups there wasn't a change in absolute range, but there was a change in the variability between groups. Again, something that I think is quite important. And they suggest that we need to look beyond the resolution of pain when we are thinking about rehabilitation. And that ties back in to this understanding of the kind of trajectory nature of lower back pain. Are there behaviours that might maintain these things and create reoccurrence in these peaks and these troughs that we see that characterise long-term back pain that people have over, so many years, and it blights them, massively so. So really important. And this paper was actually kind of recreated a couple of times, once in 2002, once in 2012, and they found exactly the same thing. Here again, on the right-hand side, we can see some kinematic data. So in comparison with healthy participants, the gait of patients with low back pain was characterised by more rigid, less flexible pelvis-thoracic coordination. Again, Same thing by the study by Van den Horn, and they put it down to potentially increased trunk stiffness, which makes a lot of sense. Not that everything that makes sense turns out to be true, but certainly I think it makes a lot of sense that we see some of these kind of behaviours. So we need some take-homes, right? We haven't quite finished, but we have some take-homes here. So people with chronic back pain do appear to move differently. There's a whole bunch of data. It's not exhaustive. I've pulled out a bunch of papers that I use when I teach, characterised by less variation and less movement. I personally believe it's good to look at these things not as causative, because I think that's a big rabbit hole to go down. I think it's much more likely to be an effect than a cause. But when we're looking at something that's chronic and has peaks and troughs, then effects can be important as causation further down the line. Could it maintain a problem? Undoubtedly, I think that's a hypothesis that we have to entertain. We have conditioned behaviours, we have conditioned responses to pain. Really, really important, again, when we come back to that U. And again, when we come back and see that strength, conditioning, activity, for a whole bunch of people may not be important, all right? But for a whole bunch of people might be important. So we have to entertain variable hypotheses rather than looking at this singular answer that's just going to kind of, create this magic response, right? So what do we do about it? That's the real question. And I wouldn't suggest that I have any answers. These are just considerations that we have to think about. So I like to think that we can encourage relaxed, free flowing movement, that we're not, looking to create stiffening, and we're not telling people to maintain neutral spines all the time, and we may be giving them variable tasks to do. And we're focusing on, and kind of Louis Gifford said it the best, that faultless, fearless, flowing movement. And I think we forget that in rehabilitation, especially as we think more about conditioning. I'm not worried about the tissues sometimes. I'm just worried about people enjoying moving and feeling free and relaxed. So can we measure these things always? No. One of the reasons I think we measure strength so much is because it's easy. We just get you to do some weights, or we get you to do things that are quite easy to measure. It's much more difficult to measure some of these things. So, we can only measure how it makes people feel. But one of the caveats to that, with like everything else, is that we may not need any of these things to change, even though we've focused on these targeted aspects. So this is a kind of a paradoxical nature, right? That it's probably good to focus on some of these things, and it gives us direction and focus with what we're doing. But at the same point, it may be that none of these things need to change, which is, a bit mind-boggling and mind-numbing. But we just got to kind of suck it up a little bit, I think. So another one of the things I think we have to think about is people's pre-movement behaviours. Is that actually before they move, do they start to stiffen and brace and hold their breath, etc.? And potentially that's something that we could look at as well. So I'm going to have an absolute revelation. Why not focus on a few things? Again, my mate Nick Tuminello, good friend of mine, talks about exercise being like a balanced diet. And I think rehabilitation is that too, that we should be giving people lots of different stimulus and vitamins that have an effect on them in different ways. So we can have exercises for strength and confidence building, and other ones that maybe are more varied and encourage free flowing movement or natural tasks. Or we may have other ones that are about explosive demand, or we may have other ones that are about range of movement. Should we still stiffen our trunk? Absolutely. We still want to stiffen our trunk, right? But it might be that we need to be able to switch between being stiff and being relaxed, and that's the key. Rather than saying, well, you need to relax and you need to stiffen up. Well, actually, we might need to do both, and give people tasks that require their, neurological and muscular systems to actually switch on and create some of these effects. So what do we do about it? I don't know, but I think we have considerations, and it all has to be a little bit of trial and error, right? So just getting into the final bit now, which exercise works the best for lower back pain? Dun, dun, dun. And again, I don't really know, I'll be honest. There's lots of different data, so we have some considerations to think about first. So what are our criticisms of a lot of these exercise comparison studies that we see? So often we test two exercises with no control. And what that means is that we don't, even if they are, there is no difference between the exercise, there's no superiority, neither of them may be any better than not doing anything at all. So we have to also think about the regression to the mean here. Just because two exercises one isn't superior. Doesn't mean a fourth or a fifth or a seventh or a 12th exercise might not be the right exercise for that person. So I don't think out of testing 2 exercises we can simply say there is no better exercise for this person, or there is a better exercise. I think it's a poor reasoning process. Another factor is the external validity. External validity is massive with exercise studies. You know, getting people to do things within a study often minimises some of the kind of adherence issues, or they do things like intention to treat analysis so that we don't have dropouts, or we take the data from dropouts and use it in various different ways. And one of the criticisms of intention to treat is that there isn't much information about intention to treat, so you can manipulate the data a little bit. So single factor thinking is another thing. You know, just because you saw benefits from an exercise or no difference between 2 exercises still doesn't mean that it's the only thing to do, or that is something that's going to be the best thing to do. There still may be loads of different factors across the biopsychosocial spectrum. And again, a really important thing is we often see sedentary groups. So that if you are sedentary, you're at the left side of the U, that anything might work. It's not this magic exercise, or it's not that any, you know, it's just that anything might work. So sedentary groups might not tell us about very active groups, and sedentary groups might not tell us about people at the bottom of the U either. So there are, you know, just because we have a whole bunch of studies, it doesn't mean exercise is magic and everyone just improves. It might be a regression. And it also doesn't mean that one would be superior, or it also doesn't mean that nothing matters, because adherence is a real big factor as well, right? And it's been so hot in London, I'm absolutely sweating my, well, I won't use that phrase live on Facebook, I'm sweating my cute little behind off, okay? So this was another paper that found that lots of different exercises seem to be beneficial. So again, we do have caveats to that. I think it's really important we point out. They found that core stability stabilization seemed to work. They found that also kind of strength-based stuff seemed to work. And again, if you were to create a really, really good rehabilitation program, would you use the same exercise the whole way through? So if I had a whole bunch of stabilization style Pilates exercises, I would use that in a more sensitive stage. As someone became more resilient or more robust or stronger or whatever the F you want to call it, I might start to think about using more load. And we see that when we look at exercise studies that involve higher load, they seem to be more beneficial for people later stage of their rehabilitation. So important that we don't see it again as there's one exercise that's best for everybody, or that there's one exercise that we should use consistently throughout a whole rehabilitation program. That simply might not provide load over an extended period of time. Again, we go back to the trajectory. So again, we might provide an exercise that's low load, that's right for an acute on chronic, but actually when they become, as the symptoms decrease, we're not creating a stimulus to stop these symptoms coming back, or any kind of adaptation to stop these things coming back. So how do we look at these things across different scenarios? So this was a paper on deadlift training. And really, really interestingly, deadlifting has been kind of promoted as this amazing panacea exercise, you know, that if you feel strong, you are strong, even though people that have lower back pain tend to be okay anyway, but let's not get me started on this. And this paper was really cool. One of the potential confounders between the high load group and the low load group, because what they did here was it was a comparison of high loading and low loading. And there was a number of different papers that came from the guy's name down the bottom that's cut off my screen, Lundgaard, out in Scandinavia somewhere. It was a PhD thesis from a number of different papers were taken from it, with a kind of a really long-term follow-up of low load versus high load. Again, 12, 24 months, we're not seeing any difference. And there's also another paper on which are the most beneficial times to introduce high load exercises such as a deadlift. But what was cool here is they gave both groups pain education. Now, we could see that as a potential confounder, because obviously to be able to run, like an analysis of variance, both groups shouldn't contain a similar variable, because you're not going to see variance in something that contains a similar variable, right? I think that's one of the assumptions of an ANOVA, as I remember it. But what they did here was they individualized it around thoughts and beliefs. So it could be said that, again, that, that's a confounder. But as individually based, you may expect it to be less of a confounder. I don't know. But what they found was there wasn't any difference between high load and low load exercises, and that actually low load exercises seem to improve function better than high load. What they did find was that deadlift training wasn't kind of better at any point, but that if you were going to use deadlifts, it benefited people that had a lower pain intensity and higher performance. So as they, people who had less severe back pain and also maybe had sufficiently recovered. But at no point was the deadlift better. It's just people got better benefit from it at different points. Okay, that's I think a couple of people have misrepresented this paper, unfortunately. Cool, moving on. So here we looked at core stability exercises versus general exercises. And this again was from 2012, a group out in China, PLOS One, very well respected journal, high impact factor. And what they found actually again was at 6 month follow up, there was no real difference between either the core stability work or the more general exercise. What they did find interestingly is at 6 weeks there was a trend that people who were in the Pilates group or the core stability group had improved more than the other group. Now, one of the things that may be down to is expectation of clinically meaningful treatment. It may be that people believed what they were getting was better. It's very, very difficult to blind people to the different types of exercises they're going to get, whether it's a Pilates style one or an exercise bike or a cross trainer or going out for a walk. All right, so it's very, very difficult to blind people in these exercise studies, again, which is a potential confounder and a caveat, and maybe limit some of the external validity of the science. But 6 weeks, we see that potentially core stability low load exercises were beneficial. Again, is that because people believe they are more? Is it that they provide novel stimulus? Is it that they're targeted to the area, which might affect belief structure? Again, I think it's important, rather than say, well, let's spin it, core stability exercises are no good. Why might they have short-term benefit? And I think that's really important that we take out the best components that we find. So I'm certainly not going to suggest that core stability exercises or Pilates style stuff has no effect, has no better effect, which is not how it's sold. But certainly could it have a potentially beneficial effect based on your assessment of someone's current state? And I think we probably have to say yes. Here we see an aerobic walking program versus a muscle strengthening program. Again, we see that it's all on sedentary patients. So actually the walking program was no worse or no better than strengthening for the lower back, specific strength exercises, which I think is really important to understand, because maybe people don't have access to gym equipment, maybe they don't enjoy going to the gym, they don't have confidence, and you can suggest that walking is good if they are sedentary, if they are at the top of that U. That's really important. So again, why do we pick exercises? Why might I choose a certain exercise? I think that's important. So when we see no clear superiority, I think we have to think, what do people enjoy? What do they enjoy doing? What gets them out of bed, especially if they're sedentary? What are they going to do? What have they stopped doing? Is there a factor where they are more sedentary, and just getting people active can be important? Asking how easy is it for people to do stuff? If we start to give them all these deadlifts and other things that are just impossible for people to do because of access, or potentially because of experience or whatever, then it's going to be impossible. So these comparison studies help us understand there doesn't seem to be a universally objective, clear exercise that is better. Doesn't mean there isn't better for the person. I think if we gave someone who was very athletic and very strong a whole bunch of low Pilates style exercises to do for the duration of a 12-month back pain, well, that would be pretty stupid as well, right? So we have to think about what the people find influences of them, and how are they going to get doing this stuff. So again, how relevant is it to what they want to do and their functional outcome measures? And again, using things like functional specific, patient-specific functional scale. Why is that important? Well, because again, if someone doesn't believe that it has a huge influence on what they're trying to achieve or their goal, or it's previously been done to them without benefit, then, that's something that we have to address. That prognostic factor we had that Rachel Chester paper again last year. We've had work from people like Joel Bielowski 2010, Predict Expectation, Carroll 2016, and they're all discussing, you know, this idea that people kind of, you know, need to connect with what we're trying to get across, right? So you have to ask yourself the question: how many rehab programs end up like that, like the IKEA table that sits in the living room because you haven't got a clue how to make it, or follow the instructions, or access to a tool, or there isn't the right equipment and the bits are floating around and there's a nail missing, etc. So are our programs better than that? Are they person and patient centered? So this is what I want to avoid, right? But that means that some guy, it might be that deadlift is great. Someone else, it might be that that's just irrelevant and it's just not going to get done. So we just need to stop with these simple single factor answers that we can try and use universally across people. There just seems to be just no data or evidence to support that. And if we pride ourselves on being evidence-based and critical thinking, then, you know, we need to think about that. So these are my keys to a great rehab program. You know, look, these are my keys. They're my objective kind of, subjective type of view of all this. So does it fit in with work and family life? Again, there's some really great data that suggests that, you know, if exercises don't fit in with people's work, family time, they don't get done. As few exercises as possible. More time, more complication, less they get done. Minimal, easily available equipment. Again, if you haven't got the equipment, it ain't going to get done. Instills confidence and a sense of self-efficacy. If you don't have the confidence, it ain't going to get done. If you don't like it, takes into account your preferences, it ain't going to get done. Now, there's been some criticism of preferences recently. So preferences for me are that we know that movement and exercise have shown promise. So within that evidence-based boundary of something showing promise, it's very important that we say, well, this is the cure, but amazingly, or potentially an aspect of the cure, but amazingly, there's loads of different ways to take the poison. You know, so let's take take the medicine. So let's take the medicine that tastes the best to you. It's not saying treatment is just going to say, what do you want? Do you want acupuncture? Do you want mobilization? That's not the point. Within a well-studied area, although well-studied doesn't always mean that potentially we are any clearer, but within an area that tells us we can be free and thinking about these things that we can take into account preference, utilises best available evidence. Again, in the case of back pain, that tells us that there's lots of different ways to skin a cat, can be easily regressed or progressed. So simply, how do I help that person kind of provide the right amount of stimulus, or is being aggravating, pull it back. Recent papers on exercising in pain. Again, we need more definition of parameters, but certainly we could say, if we define with someone what is acceptable in terms of, you know, sensation to them, and within that boundary, can we progress to get the right dosage or enough of a dosage? Is meaningful and relevant just means, does it have an impact or an effect or fit in with people's narrative or their belief structure? And if it doesn't, can we find that out? Can we attempt to help people change perspective? And finally, I think is important that fits into kind of, you know, this kind of work, family, lifestyle factors that we can be performed in any location. So they're the kind of things that I'm going to think about. So look, I said I wanted to do an hour. I'm absolutely sweating in my study. It's absolutely sweltering in here in London. British are really great at suggesting that, you know, we've got such terrible weather, and when we get a bit of decent weather come along, we all moan that it's too hot and we're sweating and what have you. Definitely the case in my house. But yeah, so cool. That's kind of a little view, and getting into back pain, I managed to do it in my hour slot. I hope there was an element of critical analysis. I hope there was enough information and evidence. And I think we have an idea that we can have an effect on people very positively. There's lots of different ways that we can skin a cat. There's a few belief structures amongst, you know, both therapists and trainers and within patients and clients that maybe need to be altered and shifted. And also, you know, everyone is kind of a different cat, man. You know, we need to understand and appreciate that and realise that there's not many simple, objective answers. Well, there might be some simple answers. Let's not say that. You know, people suggest, you know, simplicity is a key. We don't really have a definition of what simplicity is. It means a whole bunch of different stuff to different people. So we need to go a bit further into that if we're being critical and objective. But certainly, I think that it comes back down to being individual and person centered, and we can be that within, if we are looking at their subjective factors and we're understanding people and their belief structures and their preferences. I think we can still do a really good job with back pain, but we need to lose that idea that there's this one thing to do or there's this one problem, and you just need to deal with it. It's a little bit more than that. Well, look, I've really enjoyed having a chat. I don't know if I'm going to be able to do any questions. I might see if I can do 5 minutes of questions. I don't know if I'm going to be able to. Have we got anything going on here? Not sure. But anyway, cool. I'll have a look at some of the questions and maybe come back to some people. So look, problem with using this OBS software is that it doesn't allow good integration with Facebook and the stream because it's got a bit of a delay going on. So I'm doing this last week and you're only just hearing. No, you're not. It's not that. The delay isn't that bad. But cool. Right. A pleasure. Signing out.